All right, so we have about, let's see, a little less than 2 hours to get through 4 hours of stuff. So let's see how fast we can talk, shall we? All right, so for those of you who don't know me, my name is Dr. Heyman, and today we're going to talk about Introduction to Pharmacology. This is a brand new lecture for Fundamentals course, so we're going to be recording things also, so if you say stupid things, you will be caught on video. But that said, there are no stupid questions. There are only... Well, let's just not talk about that, shall we? All right. So here are some important concepts that we need to understand when it comes to drugs. So the very first thing is, what is a drug? So a drug is something that causes a change in the body. Now, you might be thinking, well, doesn't everything cause a change in the body? Yes, including food. But we're going to be talking specifically about chemicals that can do that. Now, there's this idea of what's called a prodrug. A prodrug is the precursor to a drug. So imagine for a moment that this right here represents a drug, okay? So, and that whiteboard represents your body. So when we apply the drug to the whiteboard, what do we get? We get a change, right? Right, yeah, okay. So what happens if what we actually swallow isn't active? Nothing's happening. This would represent a prodrug. In order for a prodrug to work, what has to happen? So weak. Needs to be activated. What would typically activate a drug or a chemical? Well, Dr. Heyman, I was told I'd never need to know chemistry again. Say again? No. Starts with an E. An enzyme. Okay, so enzymes are responsible for activating prodrugs. Next we have what? Pharmacology, the study of drugs. That's kind of very generic. In next semester, you guys are going to take an entire course dedicated to pharmacology. But for right now, we're just introducing the topic. Next, we have something called pharmacotherapeutics. Very big word. What does therapy mean? You guys were just learning about alternative therapies, but you don't know what therapies are? I don't know. So therapy is how we help improve the patient. So pharmacotherapy is the use of drugs to improve the patient. So typically the treatment of diseases with drugs. Then we have this idea of effectiveness. Now, how many of you want to take a drug that doesn't work? How many of you have ever taken a drug because you had a headache or some sort of pain and you wanted the pain or the headache to go away? So you took something for it. And how many of you were thinking as you took it, you know, it'd be really nice if this drug doesn't do anything? Or did you want that drug to do something? Do something. So the degree to which a drug does something is called its efficacy or effectiveness. So we want drugs to be effective. But we also want them to be safe. How many of you, when you took that drug for your headache, thought, you know, this might kill me? Or were you thinking, I'm sure it's safe. They wouldn't sell it to me otherwise. So what we want is we want our drugs to be safe. There's a couple different measures of safety. One is therapeutic range, and the other is called therapeutic index. We are not going to talk about therapeutic index at all today. We'll talk a little bit about that when we get to Patho Pharm next semester. We are going to talk about therapeutic range a little bit later. And that has to do with blood levels, and we'll be talking about that later. So keep that in the back of your mind. Now, selectivity. How many of you, when you took that that medication for your headache, were thinking, you know what? I hope this also makes my heart rate go really, really fast and keeps me up all night? Or were you thinking, I just want the headache to be gone and then that's it? Okay, so how selective a drug is going to determine how many other things it affects. Now, we're going to preview ahead to how drugs work. Most of the drugs we take are going to work by activating or inhibiting receptors in your body. Now, a drug can be highly selective for a particular receptor. But if that receptor occurs in multiple places in your body, guess what? That drug's going to work in multiple places in your body. So the selectivity is about the drug's ability to affect only one type of receptor. But we also have to take into account where those receptors are located. So outside the scope of today's introduction, but one of the things that you're going to be needing to learn in the future is where do these different locators exist in your body. Does that make sense? All right. Next, we have reversible action. How many of you were thinking as you took that drug, you know what? If I accidentally overdose taking this one pill, I hope there's no antidote. Really? You were thinking to yourself, you know, if I accidentally overdose, it would be really nice if there were like an antidote that could save my life. Yeah. So that's reversible action. The next concept is predictability. How many of you, when you take a drug, you're like, you know, I hope it works, but if it doesn't work, that's cool too. And if it makes me worse, that's awesome also. And, you know, man, I usually take two pills when I have a headache, but sometimes it takes 4 or even 8, and that's cool too, because I don't really care. I don't really want to know ahead of time what to expect. Oh, wait a minute, you're nursing students. You're high-stress people. You're like, tell me what to expect now, or I will kill you. Do you not understand? I cannot live with uncertainty. Yeah, I know nursing students. All right, and the last thing is, how do we give the drug? That's called administration. So we do not give meds. We do not pass meds. We administer medications. So the way that we actually administer them is called administration. And there's a lot of things to think about when you administer drugs, and we're going to go through some of those today. All right, some additional concepts, interactions. Certain drugs and certain foods and certain herbal supplements can interact with other medications. And that can make a drug less effective, or it can make it more effective. It can even make it toxic. So we have to be aware of what those interactions are. Next thing is drug cost. How many of you, when you have a headache, you're like, you know what? I would love to pay $200 for one pill. How many of you guys have migraine headaches? You know, when Imitrex, which is the very first of the triptan drugs that we used to treat migraines, came out, it was $200 a treatment. Anything to stop the migraine. Yeah, what we would like is a drug that costs pennies, right? No, I own stock in Pfizer. I want it to be millions. Yeah. The next one is chemical stability. We want our drugs to work, and we want them to store. How many of you currently, right now, have drugs in your medicine cabinet that are at least 10 years old? And if not yours, maybe in your parents'. How many of you are like, I don't even remember what this drug is? Should I throw it away? No, let me keep it just in case. So we want our drugs to be chemically stable so that they work for a long time. One of the things we have to be aware of when it comes to giving drugs is what is the expiration date on the medications that we're giving. The next thing is the name. What we like is a drug name that is easy to remember, easy to pronounce, and most importantly, easy to spell. And not easily confused with other drugs. So every drug typically has 3 names. We'll talk about those a little bit in a minute. And then therapeutic objective. Now, as a nurse, this is one of the most important things when it comes to a drug is why am I giving this drug and what do I expect it to do to my patient? If you can't answer that question for every drug you give, guess what you probably shouldn't be doing? You probably shouldn't be giving drugs out to people. Here's this medication, I don't know what it is, and I don't know what it does, and I don't know what it's supposed to do, and I don't know why you're taking it. But here, take it, because the doctor said so. Is that a very good attitude to have? Or is it, I know exactly why you're on this medication, I know exactly what it should do to you, and I know what might happen, and I'm going to be looking for those things. Because if this drug doesn't work, I'm going to let the doctor know, and we might be adjusting your medications. Which of those 2 nurses would you rather have caring for you? For your grandmother? How many of you hate your grandmother, so that way I don't use that metaphor later? No? We're all good with grandma? Okay, let's check in. So, intensity of the drug response. The intensity of the drug response, look at this. Super important vocabulary. You need to know these things. So, the way that we administer the drug is called the route. And we're going to go into more detail on route in a second. Medication errors in the drug administration process are the number one kind of medication error in the hospital. So the nurse was supposed to give it by mouth, and she gave it IV instead. Does that make sense? So that kind of error is the number one most important. Now, this word patient compliance, just so you're aware, there is a little bit of controversy over this word because the word compliance comes from the root word comply, which means you will do what I tell you. But as healthcare professionals, are we the boss of our patients, or do they hire us to help them? So the more politically correct term now is adherence, patient adherence. They are not adhering to the plan. Now, if you're smart, what are you thinking about when it comes to a plan? Say again? You want to include the patient in that plan. Because how many of you ever had this talk with your loved one? So I think we should do this. I disagree. And then the next day you do that and they're like, what'd you do that for? Well, didn't we talk about this? And like, yes, we talked about it, but I didn't agree. How many of you ever had that talk with a loved one? But didn't we talk about this? Well, yes, we did, but I did not agree. So if the patient doesn't agree, if they're not on board with the plan, are they ever going to adhere to the plan? So if they don't understand the plan, will they adhere to the plan? No. So that word adherence implies that there's a partnership between us and the patient. So that's all I'm going to say about that political issue at the moment. But I keep the word compliance in here so we can have that little conversation. It's beautiful. Next, we have something called pharmacokinetics. What does the word kinetic mean? Movement. And in this case, it is the movement of the drug through the body. What's the first step of getting the drug through the body? Getting the drug in the body. And that, interestingly enough, is going to be called absorption. So the route that we give it is going to affect the absorption. Next, we want the drug to move from wherever we administered it throughout the body, and that would be called distribution. The most common way that we distribute drugs through the body is going to be called, well, you're never going to guess this one, it's really hard. I can hear your heartbeat pounding with the nervousness right now, because you're never going to guess. Well, I didn't actually think you weren't going to guess, but okay. Try and guess. Blood, right. So blood distributes the drug throughout the body. Next, we have metabolism. That is changing the drug, and we'll talk a little bit about that in a few minutes. But there's basically three really big possibilities. One is we activate a prodrug. Second is we break an existing drug so it doesn't work anymore. That's called inactivation. And then the third is that we change the drug to become either more or less potent. We'll talk about what potent means later on. And then the last thing is we want to get the drug out of the body, and that is called excretion. And we'll talk about that too. Now, next we have this idea of pharmacodynamics. Now, what does dynamic mean? How it works. So how many of you have ever had a not very dynamic speaker? So the next concept is pharmacodynamics. Pharmacodynamics is the study of how drugs work. On the other hand, you might have someone who is very dynamic and said, this is how drugs work. It's pretty cool. I'm like, we're going to study that stuff, and you're going to like it. I know you don't think you are, but you're gonna. So dynamics is how drugs what? Work. Kinetics is how drugs move. All right, so when it comes to how drugs work, most of the drugs that we take, like I said before, are going to interact with the receptor. And they would do typically one of two things. They're either going to enhance that receptor's activation, or they are going to block it from being recepted, from being activated. So a drug that enhances the activation of a receptor is called an agonist. So now you get to go back to Humanities 1 and your Greek plays. So what does the word agonist mean? No, that is antagonist. So usually we put something in front of agonist, so antagonist or protagonist. So the protagonist is the number one what? actor. And what is the antagonist? The person who acts against the protagonist. So when we say that the drug is an agonist, it is acting like the receptor. A drug that blocks a receptor's action is called an antagonist. So we don't have protagonists here in pharmacology, pharmacodynamic land. What we have is agonists and antagonists. But as it turns out, we also have some drugs that are a little, well, how do you say, identity confused. And they do both agonist and antagonist at the same time. So just to give you an example of one of those is buprenorphine. Now, how many of you have ever heard of this horrible thing we have called the opioid crisis? What is it? Man, you just look at an opioid drug and you like get addicted, and like next thing you know, you're like in Skid Row, you lost your job. I mean, you don't even look at the drug. Don't look. So, what's the problem with the opioid crisis? Okay, it is addiction, but what's the problem with the individual person? What happens if they take too much? They could die. Of what? An overdose. So, buprenorphine is a drug that is a partial agonist and antagonist. So when you give it to a person, it stimulates the opioid receptors just a little bit so that the person who's addicted feels like, okay, I'm not going to die. I'm not going cold turkey, man. I'm cool. But at the same time, it blocks those receptors from other drugs. So that if they take heroin, guess what? They're not going to feel like they took heroin. So what that does is it allows an addict to feel like they can be a normal person and function, but it prevents them from overdosing on other opioid drugs. Does that make sense? So that is an example of a drug that is a partial agonist, partial antagonist. All right. Patient's functional state. This is basically just saying that how the patient is living is going to affect things. Let's just give an example of diabetes. Type 2 diabetes is caused mainly by an interaction of genetics and being overweight. Now, how does a person become overweight? Too much food and not enough energy expenditure. So if a person says, you know what, we have a magic pill. I take the pill, it lowers my blood sugar, and that's cool, man. I can eat as much as I want now. Is it going to be as effective as a person who says, you know what, I've got this pill that's going to help me lower my blood sugar, but I still need to be careful and eat less and do more exercise? Which of those two patients will the drug probably work better for? That second person. So functional state is just how the person is in the world. And as nurses, one of the major things that we need to do is to educate patients about how they can enhance the therapeutic effect of their drugs. Does that make sense? Okay. Last one on that part is placebo and nocebo. How many of you, when you were kids, you're like, I'm sick, I need medicine. And so your parents was like, you know, get out this little spoonful of sugar, and they're like, yeah, put a little bit, and here, take this. And then you found out years later that it was just sugar and they weren't actually giving you real drugs. But you're like, oh, thank you, Mommy, I feel better now. Okay, now, apparently none of you had parents who did this because none of you raised your hand. But you're laughing, which makes me think that it happened to your brother or sister. So, unfortunately, because it's often associated with sugar, some people think of placebo as a sugar pill. But that is not what placebo is. Placebo is the effect of a drug that happens because we expect it to work. So in Disney terms, the original Disney, not the remake, it's a magic feather. So for those of you who've seen Dumbo, the original Dumbo, he can't fly because he doesn't have the confidence. So the crows give him a magic feather, and all of a sudden he believes that he can fly, and the next thing you know, we got ourselves a flying elephant. So if you give a drug that a person expects to help them feel better, a lot of times they will in fact feel better. And when you study the drug, one of the things we have to figure out is how much of the drug effect is because of placebo. And on average, it's about 20% of patients are going to get better even if the drug doesn't actually do anything. Now, the opposite of that is if you expect something bad to happen, it will happen. And that's called nocebo. So if you tell a patient, hey, this is chemotherapy, and you know what happens with chemotherapy? You're going to vomit your little brains out. There will actually be people who start to vomit before the drug gets in them. We call it anticipatory vomiting. There was a doctor a couple of years back who's like, you know what, I don't tell my patients that they should expect that, and guess what? Most of them don't get it. Now, I don't know all the details of what else he was doing. Perhaps he was giving them medications that help nausea and just not telling them to expect it. What I do know is that our brains are very powerful for both good and bad, and you as healthcare providers have a really important part to play in the narrative that patients tell themselves. Do you know what a narrative is, by the way? How many of you ever heard that word, narrative? What is it? It's a story. So the story is, I'm going to take this drug and I'm going to get better. I'm going to take this drug and it's not going to work. I'm going to take this drug and it's going to make me worse because it made my dad worse. My dad took this drug and then he died. The drug killed him. It's going to kill me too. I better not take it. That's a narrative. So as nurses, we have a very important part to play in forming the narratives in our patients' brains. So giving medications is just not here, take this drug, the doctor ordered it. You have to understand what the drug does, why it does it, why it's being given to this patient, and what they should expect. Does that make sense? Okay. So some individual variation. Physiological variables are just how the patient's body works. So a person who has more fat is going to have a different reaction to someone who's less fat. Someone who is bigger is going to have a different reaction than someone who's smaller. In fact, it's such a big difference that when it comes to children, how do we typically dose children medications? Based on weight. Once you get to adult size, we figure, there's not that much difference between, say, 120 and 200 pounds, but there's a huge difference between 20 pounds and 80 pounds, right? So, and even then, there are some drugs that are still based on weight all the way up. So those are just some examples of physiological variables that can affect things. Next, we have pathologic variables. What does the word pathologic mean? What is pathology? Disease. So in this case, we're talking about the disease things. So a person who's got a blood pressure of 142 over 98 is probably going to be a little bit different in their response to a medication that lowers blood pressure than a person with a blood pressure of 200 over 122. Does that make sense? Okay. So the severity of the disease and what the disease looks like is going to affect how the drug works. Next, we have genetic variables. How many of you guys look exactly like the person next to you? How many of you have a twin? No one has a twin? Well, imagine you did have a twin, and they were an identical twin. Would they still look exactly like you, or would there be some little minor differences? Some little minor differences. So the genetics that we have inside of us affect how the drugs work. How many of you have ever taken a Benadryl, and you were like, I'm so tired, I'm dead. 3 days later, you're still like, I'm like a zombie. How many of you take Benadryl and you're like, I'm tired, but I can fight it if I really wanted to? And how many of you take Benadryl and you're like, wired? Whoa, is this the right stuff? Benadryl's supposed to make you tired. I'm not tired at all. Okay. The differences, the cause of those different reactions are genetic variables. And then finally, we have drug interactions. When drugs interact with one another, that can cause one or more of the drugs to be even stronger or less strong. So that's going to also affect how things work. All right, nursing responsibilities. You are both the pitcher and the catcher, to use a baseball analogy. What do I mean by you're the pitcher? What are you doing with the drugs? Here, take this drug. You're the pitcher. You're giving the drug to the patient. But you are also the catcher. What does that mean? You are catching the patient's response to the drug. So on the one hand, you're giving medications, but on the other hand, you're also anticipating the reaction to that medication. So pre-administration, before you administer the drug, we want to do some assessment. baseline data. If we're giving a drug that affects blood pressure, wouldn't it be nice to know what their blood pressure is before we give the drug? Oh, sure, yeah, that makes sense. How many people actually do it? Okay, the most important thing there is, if you needed to do it, how would you know? I don't know, someone's going to tell me? So you would want to know if that drug has an effect ahead of time. How would you know that? 2 ways. One, well, in nursing school, we're going to learn an awful lot of drugs. And so you might just have it up in your brain. And 2, she said a magical word. 3 words, actually. Look it up. Look it down. I don't know. Look it somewhere. Yeah, so look the drugs up if you don't know them. And if you know them, well, then it's going to be a little bit easier. Now, in nursing school, you guys are going to learn about 300 different drugs. Sorry, just how it is. When you get out onto a unit, most units are going to have no more than about 50 drugs that you see on an everyday basis. So you're going to get to learn those really well. If you what? Put in the effort. So what we're giving you in nursing school is a framework, a broad exposure that you can then narrow down later and become an expert in the drugs that you give on your unit. Does that make sense? Okay. All right. And then we want to stratify risk. What does the word stratify mean? I don't know. They use that word in A&P1 to describe the layers of skin, but I never knew what it meant. Say again? Levels. Okay. So in this case, what we're doing is we're putting the patient into a level of risk? Risk level? Why would we want to know risk level? What do we even mean by risk level? Do you have any thoughts there? Say it. Prioritize? What does that mean? That's a good thought, but not exactly. What does the word priority mean in general? What should be done first? So, if you have 2 patients, and you're giving them the exact same drug, and one of them is more likely to react negatively than the other one, which one should you pay attention to? The one with more negative potential, right? That should be your priority. So what you're doing is you're looking at these 2 patients and you're saying, I'm giving them the same drug, I'm giving them the same dose, but this patient is worse off and they're more likely to react negatively, so therefore I'm going to what? Prioritize looking at them. I'm going to pay more attention to them. It doesn't mean you ignore the other person, but it means you don't necessarily spend as much time with that person. Does that make sense? So that's what we mean by stratification of risk. Now, planning and implementation. What does this sound like to you? Assessment, planning, implementation, ADPI is a nursing process. Okay, so planning is how am I going to do this? What is my goal in getting this done? And then implement it is the actual doing of it. Now, the 500 rights. When I was your age and I went to nursing school, there were only 5 rights. But now they've been having babies and there's 11. Okay. And I'm sure by the time you graduate, there'll probably be 13. So you got to know the rights. We'll talk about that in a second. Understand the correct dosing range. One of the things, you're the very last person, you're the last safety measure before that drug hits the patient. So the physician or nurse practitioner or PA is going to order a medication. It's going to be verified by a pharmacist. Then you're going to get the order and you're going to give the medication. So there's 3 potential places where errors can be caught and fixed. And who's the last line of defense? You. I don't know, just the doctor ordered it, take it. Is that any line of defense at all? So not only do you need to know what the medication is and does and all that stuff, you also need to have an idea of the normal dosing range. Because if the drug is the correct drug, if it's the one you expect to give, but you're giving 5 times the amount that you would normally give, what should you do? Hey, Dr. Bones, just wanted to make sure that you've got the right dosing range. Do you realize this is 5 times the usual dose? Yes, that's because this patient has an unusual condition, blah, 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 blah. Oh, okay, cool. What? 5 times the dose? Oh, how'd that happen? But it won't happen unless you are doing your part, which means you have to know the normal dosing ranges. Now, in our classes, we're not going to spend a lot of time on normal dosing ranges. We will do that for a few select drugs, but for the most part, you're going to have to look it up because there's just so many drugs that can't do it for all of them. But you will, the ones that you give on a regular basis, you will need to know what those are. Then, appropriate safety measures. If you have a drug that makes a person dizzy, what should you do as far as safety measures go? Fall precautions, maybe warn the patient. Okay. If you have a drug that has the potential to increase a person's risk for seizures, what should you do? You haven't covered that one yet. It's called seizure precautions. Didn't see that one coming. If you have a drug that makes a person more likely to bleed, what should you do? Bleeding precautions? Yeah, sure, exactly. And if you haven't covered that yet, I'm sure you will soon. But yes, implement appropriate safety measures. All right, 11 rights. The first thing is the right patient. Second thing is the right medication. Got the right patient, the right medication, the right dose, the right route, the right time. Those are the classic 5 rights. And those are in the order that a doctor's order comes through. Medication orders come in that order, so you might as well learn it in that order. Then we have some additional rights. The right reason. Why are we giving this drug? I don't know. Doctor said so. Just do what the doctor says. The doctor is all-powerful and knows everything. True story. The right assessment. Okay, so before you give this drug, are you doing the right assessment? The right education, or sometimes it's called the right to education. So if patients want to know what that drug is, then you should tell them. And here's one of the ways nurses sometimes get into trouble. Hi, would you like to know what your medications are and do? Nah, just put them all in the cup and just give them to me. Okay. 15 drugs later. What's the little purple one do? You got 3 purple ones there. Well, I don't know if I want to take that one. Which one is he not taking? I don't really know. So it's one of the ways that people get in trouble. The right to refuse. Who's the boss of who in this relationship? The patient is your boss, so they get to choose if they don't want to take the drug. Right documentation. Now, there's a saying in the healthcare world. What is it? If you didn't document it, you didn't do it. And then finally, the right evaluation. What is the difference between the right assessment and the right evaluation? Okay, so the assessment happens before we give the drug, and then the evaluation happens after we give the drug. If you give a drug that works in 30 minutes, and you come back 5 hours later, is that the right evaluation, even if you're asking the right question? No. So the right evaluation also includes a time component. All right. Nursing responsibilities. So, evaluating and promoting the therapeutic effect. Any questions about what that means? Did the drug work? What's the promoting part? Well, if you have a drug that lowers blood sugar, what are some other ways we can lower blood sugar? How will we make that drug more effective? If the patient eats less food and does more exercise, if the patient loses weight. So that might be just a matter of education, but it also might be a matter of making sure the right diet is ordered for the patient in the hospital. Promoting compliance/adherence. If patients don't understand why they're on the drugs they're on, are they going to take them? Especially if those drugs make the patient feel bad. How many have ever had a drug that made you feel like crap? But you took it anyway because you expected it to make you feel better eventually. Well, if no one told you what that drug is, why you're on it, are you going to take it? The doctor doesn't know what he's talking about. This drug makes me feel worse. Stupid doctor. Throw that drug away. Implementing non-drug measures. Wait a minute. There are non-drug measures? How many of you have ever been in pain? Only a few of you in your lives? Wow, you guys live very sheltered lives. Okay. When you're in pain, are there things that can make you feel better besides pain medications? Like what? Name a few. Video games, rest, watching TV, but only if it's something good. Music. What kind of music do you like to listen to when you're in pain? Some of you are like, metal. Okay. Yeah, so there are lots of things that can help a person manage their pain that don't include medication. And if you've got a patient who's in pain, you're a really, really bad nurse if the only thing you do is say, well, here's your pain medication. Does that make sense? And so that goes for not just pain medication, it goes for almost everything. If you've got a patient with high blood pressure and all you're doing is saying, here's your blood pressure medication, and you're not helping that patient to lower their blood pressure in other ways, well, you have a name for that. Bad nurse. Okay. Next one is minimize adverse effects. So there are some things that we can do to minimize adverse effects. If we have a drug that makes a person dizzy, and the maximum dizziness is about 4 hours after you give it, what can we do that might help the patient not be dizzy during the daytime? Give it to him at night. It's almost like I gave you the answer in the question. So, yeah, there are some things we can do that will minimize adverse effects. Next, minimize adverse interactions. So sometimes it's a simple matter of don't give this medication with that medication. Make sure they're at least 2 hours apart. Sometimes it's we need to change medications. One of the things that tends to happen to patients over time is they accumulate medications. No doctor ever wants to take a patient off a drug that they didn't order. I don't know whether they're on it. Maybe they're on. Maybe it's important for them to be on it. Let's leave them on it. And so as patients go from this doctor to this hospital to that hospital, sometimes they accumulate medications that have no purpose anymore, but they're interacting with the current drugs. And one of the things that you guys can do is you can partner with pharmacists and physicians to try and make sure that the patient is not on unnecessary medications. That will be a huge part of reducing interactions. And it's especially important with old people, because old people have had more time to accumulate those medications, and medications typically work stronger in elderly patients. PRN decision. What does PRN mean? Oh, it means pro rata, which I assume is Latin for as needed. Yeah, whatever, show off, you know your Latin. Yeah. So PRN decisions. Now, who makes the PRN decision? Are you sure about that? The patient makes it? Are you sure about that? Well, the answer is it's the nurse and the patient in collaboration. But what if your patient is unconscious? Does that mean that you can't give them any PRN medications? I don't know, man. That's kind of hard. You put me on the spot here. Yeah. Sometimes PRN decisions are made without the patient's input. Sometimes because they can't give input. So if you're giving pain medication, this is a really tricky one. Pain management's really hard. Want to know why? No. And that is an important point. We don't know what they're feeling, but it's not the number one reason. How many of you have a little ache or pain right now that you didn't even think about until I just said that? And you're like, oh yes, actually, my back hurts right now. When you call attention to pain, guess what happens to pain? It goes up. So a couple years back, they had this big initiative called Pain is the Fifth Vital Sign. And so we're supposed to ask them every time we take their vital signs, what's your pain level? And guess what that did? It shifted people's attention to pain. And guess what? When you ask them if they got pain, what do they say? Yeah! Does that mean they need pain medication? No. But the guidelines said if they've got pain, you should treat it. So guess what we did? We treated it. Now, that's not the direct cause of the opioid crisis, but it is a contributing factor. And so now, guess what we're going to do? Maybe we shouldn't be assessing pain so much. Maybe that was a bad idea. Maybe we should just wait till they say they are in pain. So it's a really tricky thing to treat pain well. But guess you have a role to play in education and informing the narrative of a patient that there's going to be some pain, and that's expected. We have pain medication if you need it. On the one hand, you don't need it if you don't need it. But on the other hand, there's no reason to be suffering when you don't need to either. Does that make sense? Unless you're already an addict, or unless you're in this tiny little population of people that react super strongly to opioids, the chances that you're going to be addicted in a 3-night hospital stay is practically, what's that? A 0. Oh my gosh, but if I even look at the opioid, I can't do it. Yeah. So again, pain is one of those really tricky things, but it's you and the patient together, and you have a lot more knowledge than they do, which means that part of the PRN decision-making process is what? I don't know. Starts with an E. It's not an enzyme. Educating the patient as to what their options are and how they would know when they should ask. Another example. How many of you have ever been nauseated? Once you start vomiting, is it easier to stop vomiting, or would it have been better if you had never vomited the first time in the first place? It's a way easier to stop a person from vomiting than it is to stop them vomiting once they're there. So when you are talking about PRN nausea medications, what should the nurse be doing? What should you be doing? Educate them and be proactive. Don't wait until they're like, excuse me, nurse, I'm about to vomit. Could I have some medication here? The appropriate time to medicate them would have been 30 minutes earlier. But you won't know that unless you're what? Unless you're paying attention, thinking ahead, and talking with your patients. All right, managing toxicity. What happens if a patient goes toxic? What do we do? Well, the answer is it depends on the drug. But that's one of the things that you have to be thinking about. When it comes to opioid overdoses, what do? It's on the news. You guys should know this, right? What is it? Narcan. So you give them a drug that is an antagonist to an opioid. And then finally, we have patient education, which we've been talking about this entire time, so we're just going to move on from there. Okay, approval of drugs and drug legislation. Unfortunately, there is no exciting way to do this, but we're going to go through it as best we can. So up until 1906, anyone could sell anything in the United States and call it whatever they liked. In 1906, the drug had to be what it says it was. So if you're selling snake oil, by golly, it better be snake oil and not just soybean oil. Then in 1938, drugs had to be tested for safety and approved by the FDA. That legislative act created the FDA. So the FDA didn't exist until 1938. What was happening in 1938? The Great Depression. So this was actually part of Roosevelt's New Deal policies. It wasn't the original New Deal, but it was part of the follow-up to the New Deal. 1962, who was the president at that time? I didn't know it was going to be history class. I haven't done Humanities 3 yet. Who? Not Nixon. JFK, John F. Kennedy. So Kennedy passes a law. Well, Congress passed it. He signed it into law. Drugs must be effective for what they claim. So up until that point, the drug didn't have to work. It just it shouldn't kill you. But in 1962, all of a sudden now we've got to verify whether drugs actually work or not. Now, all existing drugs on the market were exempted from this. They didn't have to be reapproved. So it was just for new medications that come on the market after 1962. In 1970, we passed the Controlled Substances Act, which created what are called drug schedules. We'll talk about those in a little bit. 1992, we had relaxed procedures for cancer and AIDS. You're going to die anyway. What does it hurt as much? Try an experiment. Maybe it'll help. This was passed largely in part due to advocates. So patients and families who had HIV and cancer were the ones who were responsible for lobbying Congress and saying, hey, you guys are being unfair to us. There are experimental drugs that might help us, but we're not even allowed to look at them, let alone take them. So can we please in the interest of possibly living another extra month or two, have access to this experimental drug. So that's what that was about. 1997, we had what's called the FDA Modernizing Act. And again, it created a fast track for AIDS, cancer, and other life-threatening conditions. Manufacturers had to give 6-month notice before discontinuing a drug. So if you're going to stop giving a drug that someone's been relying on for several years, you couldn't just stop it. You had to give them a 6-month notice so that they would have a chance to plan for, well, what's going to be the replacement for this drug I've been taking for however long. The FDA can require testing in children because up until that point, they hadn't really done testing in children because of this little thing we like to call ethics. So, I mean, if you kill a child, if you kill an adult, I mean, that's pretty bad, right? But you kill a kid, what are you now? You're a monster. And no drug company wants to be accused of being a monster. So you know what they did to drugs that were going to be used in kids? We didn't test them in kids because we didn't want to be a monster. But then, as soon as the drug got approved, guess who we're giving it to? Kids. So now the FDA can say, hey, you've got to test this in kids. Clinical trial database, which lets providers and patients see what sort of trials are going on that are concerning a drug that they might be interested in taking. And then drug companies can provide physicians with articles of off-label use. Now, the FDA approves a drug for a purpose, and that purpose has got to be effective. So that's called on-label. If you can use a drug for something that the FDA has not approved, that's called off-label. The problem is, to get something approved by the FDA takes millions of dollars. And if a drug's been on the market for a long time, there may be a lot of research that shows, well, the drug can do these other things too, but there's no financial incentive for any company to go through all those procedures anymore. So drug companies are allowed to give them educational material that says, hey, here's this study that showed a benefit, but it's off-label, it's not approved by the FDA. Does that make sense? Fairly controversial, but there it is. Now, in 2002, we had the Best Pharmaceuticals for Children Act. Guess what that did? Tried to make it safer for kids. 2003, Pediatric Research Equity Act. Guess what that tried to do? Promote research of the drugs we're going to use in kids. In 2007, we had what are known as the FDA Amendment Acts, and that basically increased the resources for enforcement of existing drugs and what's called post-marketing surveillance. Once a drug is on the market and being sold, you want to be able to tell, are we having problems? Now, this was partly in response to a drug called Vioxx. You guys are probably too young now to remember, but for like 20 years we heard on TV, if you or a loved one has been diagnosed with a heart attack and took Vioxx, you may be entitled to millions of dollars. Call our attorneys now. Standing by. 1-800-CALL-ATTORNEY. Okay. So partly because of that. In 2009, we had what's called the Family Smoking Prevention and Tobacco Control Act. Guess what that did? You can't guess. It's okay. It's in the name. 2016, the Comprehensive Addiction and Recovery Act of 2016. Don't you love it when they name it after the year? So that was in part because of the opioid crisis. By the way, you want to know partly what caused the opioid crisis? Well, there's this little TV show called, what was it called now? Yeah, drawing a blank. Don't get old. Don't do that. Breaking Bad. So, and in Breaking Bad, it was about crystal meth. Well, why was crystal meth a thing? Well, because we had previously cracked down on the drug before crystal meth, which was what? Crack. And what drug preceded the crackdown on crack? Cocaine. And guess what preceded the crackdown on cocaine? Heroin. And guess what preceded the crackdown on heroin? Marijuana. So what we did was we took a drug that is basically pretty harmless. Not that it's not completely harmless, but in the grand scheme of things, marijuana is not very dangerous. And we can't have kids having fun, so we crack down on it. We make it harder to get, more expensive. So what happens? People do what? They change to other alternatives. So we crack down on the alternative, and then what happens? It's just like students and cheating. Every time we figure out one way that students cheat, what do? They innovate. So to some degree, part of the reason people are dying of opioids now goes all the way back to that Controlled Substances Act of 1962. This is 1970, where we cracked down on certain medications, and then every time you do that, it gets worse. Now, this is not a medical economics course, so we're just going to leave it at that for now. If you are interested in more, I have lots more resources I can give you. But one of the things that we have to be very, 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 very careful about is that we don't try and legislate our morality. And as nurses, we can be awfully darn moralizing. Can you believe that addict is asking for pain medication? As though an addict can't feel pain. I'm like, hello, they're addicted, and now they're in withdrawal thanks to you. So if you're not going to treat withdrawal, what are you going to do? Just complain at them? So anyway, addiction is a really difficult topic. We'll talk all about it in Patho Pharm 1 and 2. All right, drug approval process, more. So first is preclinical testing. Preclinical means not in humans. So this is typically in animals. And what we're really trying to look at is, does a drug kill the animals? If it does, let's not use it. But there's a trick, which is that humans and animals are not exactly the same, even though humans are a type of animal. So just because it's safe in an animal or just because it's harmful in an animal doesn't necessarily mean it will be the same in humans. We also want to see what the pharmacokinetics are. So what is that? How does it move through the body? And we also want to see what kind of useful possible effects there might be. Then we get to clinical testing in humans. So phase 1 is normal people, normal adults. Why normal adult human males? Why males?
Because they'll have many hormones interacting with stuff.
Well, that is a consideration, but the main one is they can't get pregnant. So therefore, they won't ever sue for, killing a baby or birth defects, which can happen with some drugs. So it's mostly about safety. Phase 2 is patients, and what we're looking at is the therapeutic utility and dosage range. We're not necessarily saying does it really do what it's supposed to do. That's phase 3. So in phase 3, now we're looking at the effectiveness of the drug. Once phase 3 trials are completed and everything else is done correctly, then the FDA will grant conditional approval, and then it goes in what's called phase 4, which is that post-marketing. So it's on the market, it's being given to patients, but when you do a sample size of 100, you're only going to pick up so much stuff. When you're doing a sample size of 5 million, well, all of a sudden some things can come out that you didn't realize. Does that make sense? So that's the purpose of the post-marketing surveillance, is to see if there's anything that happens now that millions of people are taking this drug as opposed to just a couple hundred. And then the limitations of the process, we mentioned earlier, women and children are often left out of the process, even though they'll be taking the drug later on. And then failure to detect all adverse effects because of that small sample size. And then you could also say that there are some incentives that the FDA has to, well, not be the best. Now, what happens if a private company puts out something that kills millions of people and it turns out that they didn't do things right? Would they lose money or do they get more money? They'd probably lose money, right? They might even go bankrupt. Now, what happens when the FDA doesn't do what it's supposed to and people die and all this stuff? It increases their budget. The FDA doesn't go bankrupt. They go, oh, you know what? Maybe the FDA didn't have enough money to do what they're supposed to do. Here, let's give them some more. So you actually reward them for incompetence. Some of you are looking at me like, welcome to your libertarian moment. All right, drug names. Most drugs have several names. First, we have what's called the chemical name. So in this example, N-acetyl para-aminophenol, aminophenol. So for those of you who remember your biochem naming conventions, you can tell me exactly what the structure of that drug is, right? But you could. Now, sometimes there'll also be an experimental name. Drugs have been on the market for a long time, typically don't have experimental names, but sometimes newer drugs will also have an experimental name. Then we have the generic name, acetaminophen. Then sometimes there's a different international name, in this case, paracetamol. And then the trade name or brand name, and in this case, Tylenol. Now, sometimes there'll be multiple brand names. Just be aware of that. So lots of different names. And the problem, one of the problems that we have is that trade names or brand names are often much easier to remember and spell than generic names, which can make things a little bit tricky for some patients. Because sometimes they have emotional illusions, like Viagra. Who wouldn't want to be more Viagrated? Sounds like vigorous. I'm not feeling very vigorous right now. I could use some Viagrating. Or Abilify. I don't even know what the drug does, but I'm pretty sure that I'd like to be Abilified. But it's actually an antipsychotic. But it sounds like ability. And it sounds like the verb of ability. If I'm Abilified, that will give me superpowers, right? That's what makes you Captain America. Oh, and then also sometimes there are multiple, I said that one. And then sometimes a brand name can have more than one product. So you have Tylenol, Tylenol PM, Tylenol cold and sinus, Tylenol cough and congestion. They're all acetaminophen, but they also have other stuff in them. In the case of Tums, Tums, what is Tums? It's an antacid. And for many years, it was calcium carbonate. But some Tums is not calcium carbonate, it's magnesium hydroxide, aluminum hydroxide mixture, which for many years was called Maalox. Well, guess what Maalox brand has? They have calcium carbonate antacids as well. So you can't just go by the brand name, you have to actually look at what's in the package. All right. Availability. The availability of a drug, there's three main levels. The first one is over the counter. What does over the counter, OTC mean? Over the counter. So you don't need a prescription. Now, some over the counter drugs are what's called behind the counter. What does that mean? So if it's behind the counter, you can't just go in and grab it off the shelf. What do you have to do? You have to go ask the pharmacist. But do you need a prescription? No. So that's over the counter. Then we have what's called legend, also called prescription. What does this require? A legal prescription from typically a physician, a physician's assistant, or a nurse practitioner. There are also some drugs that can be prescribed by pharmacists. So those are typically, dentists can also prescribe. So there's a number of different prescribing authorities, but they have to have a valid prescription. Then we have what are called scheduled drugs. These are also known as controlled. The 1970 Drug Control Act created what are called 5 schedules, and it empowered the FDA to choose which schedule different drugs fall into. So Schedule 5 is the least dangerous. So as an example, Lamodal, which is an antidiarrheal. Then we have less dangerous and addictive, so drugs like Ambien or Xanax here. Then we have Scheduled 3, which are dangerous and addictive, kind of moderate. An example here would be codeine. Now, one of the big differences between Schedule 3 and the next schedule down, which is Schedule 2, is that Schedule 3, 4, and 5 can be called in by a provider. So let's say that you saw your physician yesterday because you twisted your ankle, and it hurts, and they're like, just try ibuprofen, we'll see how it works. And the next day, you're like, it's so much worse. I can't sleep at all. Oh, I need something more. They can call in codeine because it's a Schedule 3. If the drug is a Schedule 2, which is considered highly dangerous and addictive, you cannot call that medication in. It has to be either a written, faxed, or one of the direct electronic prescribings. Now with the ubiquity of electronic health records, it's a lot easier to do that. But up until about the last year, it was way less convenient to be able to get Schedule 2 because of that written requirement. Now that things go directly from the EHR into the pharmacy, it's not as restrictive as it used to be. Does that make sense? So some of these include morphine, cocaine, hydrocodone, and oxycodone. Yes, cocaine does have legitimate medical uses. So Schedule 2 are very, very dangerous, but the FDA thinks that there are legitimate uses. Does that make sense? And then Schedule 1, the government believes that the dangers outweigh the benefits. And it includes marijuana, heroin, and some other stuff. Does that make sense? Okay. All right. So let's talk ever so briefly about medical marijuana. This is what's a case of state nullification. Now, the federal government, through the FDA, regulates medications with what's called interstate commerce. So for those of you who have had your Freedom American Society or public whatever, you know, or you should know, the Constitution authorizes Congress to regulate interstate commerce, right? Blink twice if you're alive. Whew. Okay, so what states will sometimes say is, well, they can regulate interstate commerce, but what they can't regulate is what happens inside a state. And so they say, what we will do is we will nullify any law that we think is unconstitutional or just dangerous, and we're going to say it's okay for our state to do that. So as long as the marijuana was grown in our state and consumed in our state, people can do it. Does that make sense? So as of the time that I wrote this, so this comes from what's called the Principles of 1798, which were written by Thomas Jefferson and James Madison. You might remember them as some of the founding fathers of our country. So when people are saying this, they're going back to the very founding of the country and saying states are allowed to nullify federal laws in this way. Some other examples of nullification include sanctuary cities. So when a city says, hey, we don't care if it's an undocumented worker, they're welcome to be here, and we're not going to enforce those laws. That's another example of nullification. There's also local nullification example. Not too long ago, there is the controversy where Virginia passed a gun law outlawing a certain number of guns, and all of the sheriffs in Virginia basically said, well, we're not going to enforce those laws. Does that make sense? So whether you agree with nullification in general or not, or the specific application of a nullification, that's basically what's happening with medical marijuana. As of the time of today, there's only there's very few states left that don't have some sort of medical marijuana law now. It's a very small minority. All right, so history lessons gone. Now back to real drug stuff. Pharmacokinetics. Absorption is the movement of the drug into the body. So here are some things that affect that. So how quickly the drug dissolves. The more quickly it dissolves, the more quickly it will be absorbed. So if you're giving a drug that is a pill, is it going to be as quickly absorbed as a drug that's given as a liquid? No. The surface area for absorption. So if you're giving a drug that's absorbed through the skin and you put this amount on, is it going to absorb as fast as something that's this big? You get the idea, right? Now, what's got more surface area, a pill or a powder? A powder. The amount of blood flow to the area. If you're putting the drug on a place that's got a lot of blood flow, it's going to absorb more quickly. And then lipid solubility and pH partitioning, those are advanced topics that we are not going to talk about. But the polarity of a drug does affect how it absorbs. All right, you've got to know these. See, super important vocabulary. Most of the drugs that we give are going to be given what's called enteral route. Enteral goes into the GI tract. So what are some ways we can put drugs into the GI tract? Okay, well, let's start with the most common one. Oral, which is called PO, per os, by mouth. Then we can put it into a number of tubes. So gastrostomy tubes that go straight through the skin to the stomach. NG tubes that go up the nose down into the stomach. And how else can we do it? Say again? So we can put drugs up the other end, per rectum, PR. Now, no matter how you give it enterally, the vast majority of that drug is going to be absorbed into the mesenteric veins, which are then going to go to the liver hepatic, or the liver splenic system, the portal vein, and they're going to be filtered in the liver. So all enteral drugs are going to be what? Filtered through the liver before they go to systemic circulation. This leads to what's sometimes known as the first pass effect, because it first passes through the liver. All right, parenteral is injections. So intramuscular, intravenous, and subcutaneous. There are some other injections as well, like joint arthroscopy, like into the joint, intradermal, which goes just under the skin. Those are not considered parenteral because they're not going to be absorbed into the bloodstream. They're supposed to act locally. But these three injections are going to be absorbed into the bloodstream, so they're called parenteral. Next, we have topical. That's when you put it on skin. But what's the purpose of the drug that we're putting on the skin? Is it to work on that area of skin, or is it to absorb through the skin? Well, the purpose is to act locally. So when we give a drug topically, what's the purpose? To act locally on that bit of skin. Now, does it mean that there won't be some absorption? There might be some absorption, but is that the purpose? No, it's to work locally. Then we have what's called transdermal. What does trans mean? Across or through, and dermal, skin. So in this case, when we put it on the skin, what are we wanting to happen? We're wanting it to absorb. So when you put on, say, a nicotine patch, what's the purpose of the nicotine patch? To absorb through the skin. So that's called transdermal. Next, we have inhaled. So certain drugs need to be, certain drugs are inhaled. I don't say need to be, but can be inhaled. And the main purpose of inhalation can be either to work locally in the lungs or to use the lungs as a distribution system. So medical marijuana, when inhaled, is which of those two? Distribution. But if you're using a bronchodilator, like albuterol, for your asthma or your COPD, what's the purpose there? It's to act locally in the respiratory tract. And then we also have vaginal. Here's some common abbreviations. You need to be familiar with these.
I had a question because you said parental is not.
Intradermal is technically not parenteral, yeah.
Okay, so what category would that?
Other.
Other?
Yeah.
Okay.
Yeah. So yeah, we're not covering all of them at the moment but yes, other. Okay, so PO per os by mouth, PR per rectum, IM intramuscular, IV intravenous, sometimes intravascular, but whatevs. SC, SQ, or sub-Q are all the same for subcutaneous. That's going into the fat underneath the skin. Transdermal, or trans for transdermal, top for topical. SL is sublingual. So this is where you're putting the drug underneath the person's tongue, and it's going to absorb directly into the blood vessels under the tongue. INH for inhaled, and VAG for vaginal. Then these are what we call schedules. These are the schedule that we give the drug on. So PRN, as needed, BID, twice a day, TID, 3 times a day, QID, 4 times a day. Now, this particular one is not allowed in hospitals according to Joint Commission rules. QD would be daily. This one is also no longer allowed by Joint Commission rules. If it doesn't mean you won't see it outpatient, and sometimes you'll still see it in progress notes. It's not allowed in orders. So orders is when the doctor says, give the patient this medication. You can't write QD in orders. But you can do it, you can write that in outpatient prescriptions. And you can still write it in the progress note where the doctor documents what they did. So you need to be familiar with those abbreviations anyway. QOD means every other day. Q is going to mean every. So in this case, Q1H every 1 hour, all the way up to whatever. Now, what is the difference between Q12 hours and BID? I mean, if you're going to give it twice a day, what schedule would you probably give it? About every 12 hours? Now, the key difference between BID and Q12. Q12 means every 12 hours you're going to give it, no matter when that happens. BID means twice a day while the patient's awake. Does that make sense? Okay. And the same thing between TID versus Q8 hours. For some of you who are like, wait a minute, math, huh? What? 24 divided by 3 would be 8. Question there?
Why is it no longer allowed to use this?
Because it was too easily confused for other abbreviations. So over the years, the Joint Commission, which accredits hospitals, if it's not accredited, it can't receive Medicare or insurance funding. So basically, it has to shut down in today's environment. So if the Joint Commission says over time, look, we've detected these certain patterns that most of the drug errors that are happening as a result of handwriting or as a result of orders are because of these abbreviations, then they'll outlaw them. So that's why. Then HS is hour of sleep, so before the patient goes to bed. PC means after meals, and AC means before meals. So you need to know those. You may encounter them in drug questions or case studies, and you'll definitely see them in the hospital. All right. That clock is completely wrong. We are not going to finish everything today. Okay, so drug distribution, blood flow to tissues. The main thing that determines how a drug distributes is, number one, blood flow to the area that you want it to work in. So typically, skin has a lot of vascularity. Feet have less vascularity. So when you're trying to treat foot infections, for example, it's going to be much, much harder than skin on the face infection. Why is that? Difference in blood flow. The other big thing that is going to affect the distribution of a drug is its ability to dissolve in fat versus water. Drugs that are highly water soluble tend to go more in the blood, less in tissues. And drugs that are more fat soluble tend to be distributed more in tissues, less in the blood. One other thing that can affect things is protein binding. Certain drugs are water soluble, but they don't just float around in the blood free. They first bind to protein. The number one protein in your blood was, what's it called? Albumin, or albumin. Don't ask me which way. You say it however you want. But you have to give enough drug so that all of the binding sites on albumin are first taken up, and then there will be drug that's free to act. Does that make sense? So elderly patients tend to have lower albumin levels than normal adults. So that's one of the reasons why they react more strongly to drugs. If there's less albumin, then that means there's more what? Free drug. All right. Therapeutic range, we're going to talk about that in a second. Metabolism. Changing the drug. Now, what is it that changes a drug most of the time? An enzyme, right, an enzyme. So what changes a drug most of the time is an enzyme. And the vast majority of the enzymes that change drugs are located in your liver as part of what's known as the P450 Cytochrome Microzymal enzyme system. Say that 5 times real fast. Now, we're not going to learn a lot about this system today, other than that it exists. Now, as far as the therapeutic consequence of drug metabolism, this is what we talked about earlier. You can accelerate renal excretion. You can inactivate the drug. You can increase the therapeutic action. You can activate a prodrug. And you can also increase or decrease the toxicity of a drug. Some other things to think about. So when you have multiple drugs that go through the same enzyme system, are they more likely or less likely to interact? More likely to interact. So over time, what you're going to begin to do is you're going to begin to learn which drugs go through the system. And then there are some drugs that don't go through the system, but they affect the system. So over time, we'll begin to learn some of those interactions. But for right now, we don't need to worry too much about that. The first pass effect that we mentioned earlier, as they go through the liver first when they're absorbed PO, That means certain drugs just don't work if you give them PO. You got to give them by some other route. And then the nutritional status of a patient. The more fat a person has, the more fat-soluble drugs are going to be distributed and stay in their body longer. Here's just some examples. You can ignore that for now. Now, pharmacogenetic testing. What do you think that is? Testing your genetics to see what drugs work better or worse? Why, yes, you're so smart. So, most of the variance in the way drugs work in our bodies is because of the genetics of that microzymal enzyme system, the P450. So, what we can do with pharmacogenetic profiling is we can see which drugs are likely to become toxic or not toxic, which ones are more likely to work or less likely to work based on that person's genetics. There are certain drugs that there's like, well, let me rephrase. There's a certain genetic variant that's very common among Asian patients that when Asian patients go to get a certain type of chemo, they won't give them that chemo until they've done genetic testing first. Because if the person has that genetic variant, then it's very likely that they'll die from that chemotherapy. So it's something like 15% of the Asian population, whereas in like the white population and black population, it's something like less than 1%. So that's just an example of how we can use genetic testing for that. How many of you have, well, we already mentioned the Benadryl example. That, again, is genetics. And then when patients go on antidepressants, it's like, well, here, try this. Well, that didn't work. Here, try this. Well, that didn't work. Well, here, try this one. Well, that made me worse. Here, try this one. Well, instead of trying 5 or 6 of them by trial and error, what if we could do a genetic test, figure out which one is most likely to work for you, start with that one. And that's the idea behind genetic testing. So here's an article if you'd like to read more about that. Okay, drug excretion. This is getting rid of the drug out of your body. So the number one way we get drugs out of the body is going to be renal excretion. You're going to pee it out. You're going to void it out. Some additional things are breast milk, bile, and you can actually exhale drugs as well. There are certain drugs that kind of like ooze out of your tongue, so you have like a weird taste in your mouth the entire time. It's kind of fun. Now, when it comes to renal excretion, we've got glomerular filtration, which is the number one determinant of how fast a drug will get filtered out of your blood. So the more your kidneys work, the quicker the drug is going to leave your system. Now, because renal excretion is the number way we get rid of drugs, wouldn't it be really nice if we had a measurement of renal function? And the way that we're going to do that most of the time is with what's called serum creatinine levels. So creatine phosphate is one of the energy pathways of muscle, and creatine phosphate gets broken down into creatinine, right? And then creatinine gets peed out, eliminated. So it's produced at a constant rate by your muscles, and it is also excreted at a constant rate by your kidneys. So as long as muscle mass and renal function are stable, guess what will happen? The creatinine level is a pretty good estimate of how much you're going to be excreting at a given moment, which means a good estimate of renal function. Now, what happens over time as people get older? What happens to their muscle mass? Tends to decrease, right? Unless you make efforts to stop that from happening. And what happens to your renal function as you get older? It also goes down. So, although it's a pretty reliable indicator in this range, down here it's not so reliable. So, 60 to 65 is this cutoff right here where it's no longer reliable. So when that happens, we have to switch to what's called creatinine clearance. And creatinine clearance can either be done directly with what's called a 24-hour urine. So you have to save all of the urine a person produces over 24 hours, and then compare that to their creatinine level in their blood. And that'll give you what's called a 24-hour creatinine clearance. It's the gold standard of creatinine clearance. Or you can estimate it with an equation. Now, you don't have to know the equation, but there it is just for funsies. But it takes into account the patient's age and their weight. And then also their sex, male or female. Why is that important? Because on average, men have more muscle mass than women at any given weight. It's not always the case, Steffi Cohen, for example, but it's usually the case. So creatinine is both a measurement of muscle mass and also renal function. And which of those two things is more important most of the time? Renal function. All right, now, two things that can also mess up your creatinine levels. So we already mentioned the problem with age, but the other is if a person eats a high protein or supplements with creatinine, that's going to boost their creatinine levels up. And the other is if a person has very, very low muscle mass. So there's some people who basically have zero creatinine. They're like bedridden people. They have like basically no muscle. So those are some additional things that can mess with the creatinine. So for the most part, what's the measure of renal function? Serum creatinine. In patients older than 60 to 65, what do we do instead? Creatinine clearance. Boom, that's it. For the test, that's what you need to know. Yeah. I told you, I threatened earlier, we're going to talk about therapeutic range. So for any given drug, there is a theoretical level in the blood that if the concentration of the drug is below that, you're going to get no effect. This is what's called the therapeutic floor. So below that, you get no effect. Then there's going to be a certain point where if you go above that, you're going to become toxic. Or sorry, minimum effective concentration. Then up here, this is called the maximum or the minimum toxic concentration. So if blood levels go above that, what happens? Patient becomes toxic. So medications, all medications are poison if you give them at high enough doses. So once you go above that toxic level, the patient is being poisoned rather than therapeutic. Below this level, no therapeutics are occurring. So what we want is we want that drug to be in the sweet spot most of the time. This is called the therapeutic range. Now, this is showing if you give a single dose of a medication, it's going to absorb and it's going to get higher, higher, higher concentration, and then it's going to top out at what's called the peak. And then it's going to slowly go down over time until eventually you get to the bottom, and that would be called the trough. So most of the time, we would want to give another dose somewhere in here, right? So it would look like this. Does that make sense? Okay. So half-life is how long it takes for half of that drug to be gone. And the 5 half-life rule, if you take, let's say you start with 100, and you take half, what do you get? 50. Another half. Another half. Another half. 6 point. And another half. 3 point. Okay, so after 5 half-lives, 97% of the drug is gone, right? So after 5 half-lives, we basically consider the drug to be out of your system. And how long a drug works therapeutically is known as its duration. Okay, pharmacodynamics. Yeah, we're going to be cool with this. We're just not going to do many drugs. All right. Again, most of the drugs that we have work on a receptor basis. So as they affect more receptors, you get a stronger response. There's 2 concepts, efficacy, potency, we'll talk about real quick. And then as far as the drug-receptor interactions, the receptor type, the selectivity for that receptor is going to affect how strongly it interacts. We use what's called the theory of lock and key. You probably learned about that in chemistry and in Bio 1 and in A&P 1, and you may or may not have forgotten that, but what's it called? Lock and key. So the more specific the drug is to the shape of the receptor, the stronger the effect of that drug will be. All right, so this is an example of what's called the dose-response curve. So here's a theoretical cell, and how many receptors does it have? 4. So in this first one, we've affected how many receptors? 1. So that's going to give us about 25% of our maximal effect. Here now we've gotten 2, then 3, so that corresponds to 50% and 75% of our maximal effect. And once all 4 receptors are activated, that's going to give us 100%. Now, if you increase the drug so that 5 receptors, wait a minute, there are no 5 receptors. If you keep giving drug, what's going to happen? You're not going to increase the therapeutic effect. Why? Because all of the receptors are saturated. And that's why this flattens out at the top, what's called an S curve. So no matter how much drug you give, you're never going to get more than maximal response. And that's called the maximum what? Efficacy. Now, not all drugs are created equal in terms of efficacy. So here's 2 different opioids. Pentazocine tops out at about half of the efficacy, or pain relief, as morphine. So morphine is a more what? Efficacious drug. Now, sometimes people will say strong, but that's not a very good descriptor. What do we mean in this case? No matter how much drug you give, morphine will top out higher than pentazocine. What's that concept? Maximal what? Efficacy. Okay. You guys are beginning to go, yeah, you were kind of fun at first, but now you're getting a bit annoying. That's okay. I'm not going to overstay my welcome too much longer. So the next concept is, well, how much drug does it take to get up to here? So here we've got 2 drugs, morphine and meperidine, or Demerol. So down here you've got the dose. So when you are given just enough dose for Demerol to begin to work, how much efficacy does morphine already have? When you've topped out morphine right here, you're only halfway to meperidine. So the concept of potency is how much drug does it take to get to an effect. So you're talking about the dose. You put the concept of efficacy and potency together, and you get strong. So when you talk about, well, this drug is stronger than that drug, there's 2 concepts that could be being talked about. And you don't know which one it is because it's not very, what's the word? Precise. So when someone talks about strength of a drug, what do you really want to know? Efficacy and potency. All right. We already talked about agonists, antagonists, and partial agonists, so I'm going to skip that part. We talked briefly about selectivity. We're going to illustrate that in a second. And then what's the theory behind selectivity? Lock and key. All right, so here we have a nicotinic receptor and a muscarinic receptor. In your body, both of these receptors are activated by a neurotransmitter called acetylcholine. So what shape does acetylcholine have in this illustration? Double hump. So double hump fits right in there, right? And double hump also fits in there, right? Okay. So acetylcholine can hit both of those. But there are some other substances around, nicotine, which is found in tobacco, muscarine, which is found in mushrooms. So nicotine can fit a nicotinic receptor, but not a muscarinic receptor. And then muscarine can fit muscarinic receptors, but not nicotinic receptors. So nicotine is selective for only one of the 2 acetylcholine receptors. Does that make sense? Okay, so that's what we mean when we talk about selectivity of a drug. How selective is it for a given receptor? Now, one of the interesting things is that if you really, really overdose on muscarine, it might be able to occasionally activate a couple nicotinic receptors. So sometimes that selectivity is dose dependent. Does that make sense? How many of you have ever put together a puzzle with your parents when you were a kid? What did they keep telling you? Don't force the pieces. So when you force the pieces of the drug by giving a much higher dose, sometimes the toxicity comes because it starts to become selective for new receptors that it's not ordinarily selective for. Drug interactions. So when we have drug-drug interactions, there's basically two possibilities. One, the effect is intensified, and two, the effect is decreased. That was hard. Man, want me to say that again? Or you think you got it? I don't even know my own name at this point, so we're all cool, man. So, drug-drug interactions, two possibilities. It can either be intensified or decreased, reduced, that's it. Now, we also have food-drug interactions. So sometimes there's absorption issues. So there are certain drugs that can't be absorbed on an empty stomach. There are others that can only be absorbed on an empty stomach. There are some drugs that absorb better with milk. There are other drugs that will never absorb if you give them milk at the same time. So that's examples of some absorption issues. Some drugs interact with certain foods to change metabolism. One of the classic examples is grapefruit juice. Grapefruit juice is broken down through one of those P450 cytochrome enzymes. So any other drug that's broken down by that same enzyme will interact with grapefruit juice. Certain drugs can increase the toxicity or decrease the mechanism of action of drugs. So for example, there's a drug that's an anticoagulant, so it makes patients not clot as much, and it interacts with vitamin K. So if patients eat too much vitamin K, the drug will stop working. On the other hand, if a person eats regular amounts of vitamin K and then one day doesn't eat their vitamin K, what will happen? The patient can become toxic. So that's pretty much what we mean by that. And then we also have food and herbs. How many of you know people who are like, oh no, I won't take drugs, I'll just take herbals? You are that person. Okay, so drugs and herbs can often have interactions. A lot of the very common herbs interact especially with anticoagulants, which can make a person more likely to bleed if they're on those drugs. All right, adverse effects. Sometimes these are called adverse reactions. Sometimes you'll hear them ADE or ADR, adverse drug reaction, adverse drug event, adverse drug effect. So the first thing is the term side effect. Side effect is any effect other than our intended therapeutic effect. So if you have a drug that reduces pain and reduces cough, and you're giving it to the patient as a cough medication, what is the reduction in pain then? A side effect. Now you give that exact same drug to a different patient who's in pain, what is the reduction in cough? The side effect. So you have to know that sometimes drugs can have multiple therapeutic effects. What is the one that's being used on this patient? Everything else is side effect. All right, toxicity, we already talked about that briefly. Allergic reactions. What is a true allergic reaction? It's an immune response to the drug. So if a drug causes GI upset and the patient has GI upset, is that an adverse event or adverse effect? Yes. Is it an immune response? No. So one of the things that patients will tell you is, oh, I'm allergic to that. You can't just take what they say at face value. Just like you can't listen to students and just take what they say at face value. Oh, they don't teach us anything. Okay, shush. All right, so you can't just take what patients say at face value because everything is an allergy to them. And so what you have to ask when they say I'm allergic to something is, what was the effect? What happened? So if you have a drug that causes diarrhea as an adverse effect and someone has diarrhea, are they allergic? No, they just don't like the adverse effect. If that person has some life-threatening problem and that's the only drug that'll work, can we safely give it to that person? Yes. And will they experience that adverse effect? Yes. And we're sorry, but we'd rather have you be alive. So allergic reactions are very dangerous, but they're not, but most people who say they have allergic reactions just have adverse effects. What does idiosyncratic mean? Yeah. Yeah, it's individual to that person. Yeah, it's individual to that person. A lot of times it's not an expected thing. It's just, that was weird. That's idiosyncratic. What's iatrogenic? That is where a medical treatment causes another illness. Now, let's say for a moment that you have an autoimmune disorder. What does that mean? Autoimmune. Your body's immune system is attacking its own body. Is that a good thing? How would we typically treat that, do you think? We would suppress the immune system. Now, what is the immune system in charge of in general? Fighting infections. So if we give an immunosuppressant, what does that do to the risk of infection? It increases it. So if a patient's on an immunosuppressant and they get an infection, what would that be considered? Iatrogenic, because the treatment caused the disease. Withdrawal syndrome. Certain drugs change your body's physiology. And if you take them off the drug suddenly, they'll go into withdrawal syndrome. This is very common in opioids. Everyone knows all about that. Yeah, you even have a word for it, cold turkey. It happens in alcohol withdrawal, delirium tremens, but it can also happen in other drugs. So when a person is on a drug that has withdrawal syndrome, what do we need to do? You taper the drug down. So let's say they're on 100 milligrams. You don't just go 100, 0. You go 100, maybe 75, then 50, then 25, then 12.5, then 6, then 1. Maybe that process takes 5 days. Maybe that process takes 2 weeks. The concept is the same. You don't take them off suddenly. Does that make sense?
That what they call step down?
That's different. Step down is you lower the dose. So you start them at a high dose, and then you lower the dose as needed. Carcinogenic, causing cancer. Some drugs cause cancer. Teratogenic. Yeah, harmful to the fetus, potentially causes birth defects or death. All right, medication errors. Now, we're at the last topic for right this moment. How do you feel about that? I feel pretty good. Okay, any preventable event that may cause death or lead to inappropriate medication use or harm. That's what one is. So the 2016 update from the FDA, medication errors injure 1.3 million people per year. That's a lot. Johns Hopkins Medical Center estimates that 400,000 deaths per year are due to medication errors. That is a figure for the United States, not worldwide. 400,000. That's almost 500,000 people. To put this in perspective, medication errors kill about 400,000 according to Johns Hopkins. Flu-related deaths, less than 50,000. All gun-related deaths, which includes cops killing people and suicides. Traffic accidents, drownings. Do you know there's National Ask Day, where you're supposed to ask if your friends' families have pools and not let them play at their kid's house if they have a pool because the kid could drown? School shoot. In the last 20 years, less than 4 kids have died per year from school shootings. You people are a bunch of murderers. Man. I don't even know what to say. So, 13 major types of medical errors, medication errors. You can read about them in your book, but 90% of them are caused by these 3 things. First one is human factors. 30% of that is performance deficit. You gave the drug the wrong way. You just didn't do something you're supposed to do. Knowledge deficit. You didn't know that you were supposed to do it. Oops. What was that keyword we're supposed to do and we don't know? Look it up. Miscalculation of doses. That means math. You got to be able to do just a little bit of math. Have they started doing math in the course yet? Oh, you have. Now, so you know the math is pretty easy. It's like 7th grade math. Not even. But you got to be really good at that. So you got to be a really good 6th grader. How many of you can be a good 6th grader? With a calculator, no less. Communication mistakes. So handwriting and confusing abbreviations. You were asking earlier about like why do they put those on there? Well, this is the reason why. Decimals, and then different units like metric versus apothecary. Apothecary is like older grains and grains, pounds, that kind of stuff. And then name confusion. So every now and then they'll rename a drug to be less confusing, which confuses the people who knew the drug to begin with. All right, decimal units. Couple rules you got to know. Numbers larger than 1. You never use leading zeros. So you would never write something like this, 0, 3, because that confuses people. If it's bigger than 0, you just put the number. Now, you would also never put 3.0 because, what is that now? It's 30, 10 times the dose. If the number is smaller than 1, you'll always use a leading 0. And you'll never use a trailing 0. Does that make sense? Okay. Then the last thing here is the handwritten number 1. What is that? Is that a stray mark on the page or is that a 1? So what doctors have done over the years is they've developed this is 1, or sometimes they'll do it like that. So both of these are 1. Now, this looks like it's 11 over 11, which is also 1, but it actually means 2. So sometimes they'll also do that. And then this is 3. Now, no one goes above 4. No one goes above 3, and a lot of people just write 3 at that point. But you'll see these ones fairly commonly if you work outpatient or in a place that uses paper charting still. So on that note, we are done with the introduction to pharmacology. However, we are over class. So there is an entire another presentation on common drugs you're going to see in the long-term care facilities, which you guys are about to go to over spring break. Because of the interest of time, I believe we're just going to turn that into a voice thread, and you guys will get the voice thread so you can listen to it over spring break. All right, see you guys later.